So this talk is a tribute to Fatima Ghazla, who has been my mother figure and has given me the opportunity to be who I am today. We have shared a deep trauma together that changed our entire lives. May she rest in peace. The views expressed here today are mine solely and not those of MAPS or BC Center for Substance Use. And if you feel triggered by anything I shared today, since I will be speaking about trauma, please take some space and time to take care of yourself. First of all, I would like to acknowledge all the hardworking healthcare professionals that are dedicating their lives to helping people heal from mental health and addiction issues. Thank you for all that you do. Trauma-informed practice is not just a catchy phrase that looks good on paper in healthcare policy. It is a non-negotiable practice for healthcare practitioners, as many patients, if not all, are traumatized to some degree. In my hospital career as a social worker, I have seen numerous psychiatrists spending extensive time and effort in capturing the current presentation of symptoms in their consultations with only 1 or 2 lines talking about the past traumatic events, almost like it's a footnote. And by the way, the person was also sexually abused from ages 3 to 5. Instead of having psychiatric consults focus exclusively on symptoms and diagnosis as a reductionist view of trauma, we need to put the traumatic experience as the title of the consults and then consider the symptoms as the framework in order to better understand the presentation and its potential resolution. We have clear evidence demonstrated in the Adverse Childhood Experiences Study, also known as the ACEs study, that this unresolved traumatic imprint of the original experience is at the root of most chronic physical and mental health conditions. Many types of physical and mental health issues, including addiction, stem from a history of trauma. Until the day comes when we fully realize this is when the system has the potential to change and make significant revisions to mental health and addiction treatment. As a trauma therapist, what I have discovered time and time again is that when you go to the depths of disorders, such as depression and anxiety, you will find internalized negative core beliefs that drive the emotional dysregulation in the nervous system and the default mode network in our brain. These negative core beliefs are loaded with emotional and physical sensations that activate the polyvagal system with the interchange of the autonomic nervous system, with the activation of the sympathetic nervous system, which shows up as fight, flight, and high freeze, and the parasympathetic nervous system that shows up as low freeze, shut down, submit, feign death, and dissociation. We also see the interchange of the ventral vagal system, the social engagement and attachment system, as well as the dorsal vagal system, which consists of presentations of depression, numbness, sense of disconnect, and shame. What we are seeing are the diverse faces of trauma in their various presentations of symptom clusters rather than actual disorders. It's time for us to face the collective unconscious shadow of the mental health system. Since the system cannot look at itself and see the flaws in itself, we have to acknowledge the shadow of the system and the huge profit made from keeping people sick and dependent on a broken system, with medication as the only form of treatment, creating short-term relief and a long-term addictive pattern with no resolution. Because if the system would actually have to face itself, it would realize that it needed to change immediately, since people are not getting better, and many are actually dying, as we are seeing in the opioid crisis. Upping the dose isn't going to change the prognosis when it comes to mental health and addiction. In my opinion, the dark side of the system doesn't actually want to change or heal because it fears that it would be annihilated and there are many stakeholders in keeping the status quo. However, based on my experience, the masses are getting tired of the med cocktail and hopelessness, as I see in the clients I see in my practice, and are looking for real solutions, so it's just a matter of time before the paradigm shifts. I've worked in emergency departments as a social worker for years, and I've seen many patients coming in for panic attacks, anxiety, suicidality, overdose, psychosomatic symptoms, substance intoxication, and other mental health crises, which are all symptomology of trauma, as shown here based on Janina Fisher's work. Wouldn't it be easier if for everyone, if these individuals had more appropriate places to go, other than getting so far into the crisis that they had to resort to going to the hospital because they couldn't bear it any longer? Instead, they walk away increasingly hopeless, traumatized by the way they were treated, and powerless, feeding the vicious cycle of trauma, and eventually making their way back to the ER, asking for more help, continuously dependent on the system that can't actually provide long-term relief. In my work in the ER, I have witnessed patients pleading at the door that if they get discharged, they will likely commit suicide, while psychiatrists escort people out with security due to being disruptive, shutting the door in people's faces. How are these ethical practices? Seems like very stressed and burnt out psychiatrists due to the systemic challenges we collectively face as healthcare practitioners. I have witnessed women having their clothes torn off their bodies by multiple security and hospital staff without the consideration for earlier sexual assault history, some as early as within the year of the incident. I have seen patients bullied into taking medication by the nurses and doctors. I have seen patients shamed for being transgendered and staff refusing to use the appropriate gender pronouns. The mental health and addiction system itself creates a stigmatizing otherness where the nurses and the physicians are segregated from the patients, whether it's through nursing stations, seclusion rooms, or restraints, creating an emotional segregation with a clear division between us and them. No different than prisoners and security guards within a prison system. What does that do to a patient who is already feeling less than and hopeless? It keeps them disempowered and feeling unsafe. I've worked in the local emergency department providing psychiatric care, where the common treatment for borderline personality disorder was borderline therapy. This therapy including getting the most uncomfortable chair in the hospital so that the patient would leave the hospital with the hope that they would never come back. Even the mental health and addiction staff are traumatized because they are working in a system where they see people suffer continuously, and all they can try to do is manage their pain without any changes. It's a hopeless ordeal, and staff end up calling in sick or going on sick leave due to the stress of powerlessness and hopelessness that is a key signature of trauma. The revolving door system creates overwhelmed and burnt out individuals who initially started as kind helpers but had to resort to protective mechanisms of hard armor and numbness against the revolving door of patients coming back to the hospital or outpatient clinic complaining of the same symptoms or increase in symptoms, for which they are given more medication that is not working and has horrible side effects. We pathologize patients for their suffering and re-traumatize them while in our care, and then send them back through borderline therapy and waiting room hoping they will never come back. How is this working for us? Why would we want to punish these patients, shame them, abuse them, neglect them, reject them? Aren't we just reenacting their childhood experience with them, making them feel like bad, worthless children all over again? How can we be so blind to the suffering of others? If we exercise a more trauma-informed perspective, these patients will be welcome into the hospital with staff knowing that this person just needs a safe place to land, a place to get some relief from their inner turmoil, a place to be temporarily safe, a place where they could interact with a professional who could assist them in stabilization with kindness. I'm going to skip through some of these slides, but I would encourage you to take note of some of these psychiatrists that I'm showing because they are doing some really innovative work with trauma and the brain. Why is the field of trauma and attachment research, as well as interpersonal neurobiology, so detached from psychiatry? How do we reconnect psychiatry to the field of trauma? I believe it's through psychedelic medicine, since these medicines have shown us the root cause of the symptoms, which always goes back to some traumatic experience, usually in childhood. We have to do better. These archaic aversion practices, therapy practices in our ERs have to go. We are in a mental health crisis. We can't maintain managing symptoms anymore. We need real solutions. We need healing. We need connection. We need psychedelics and psychedelic therapy, respect, integrity, and compassion. We need to bring love back into the healthcare system, like Jota for physician would say. So one of my private practice clients was hospitalized in a mental health unit in a local hospital after being taken against her will and certified for what appeared to be psychosis NOS. If the physicians were aware of trauma-related dissociation and the symptoms of structural dissociation, they would come to understand that her presentation is rooted in trauma and not psychosis, and that the voices in her head are actually fragmented representations of her dissociated self due to childhood trauma. Instead, she was placed on antipsychotic medication for the first time in her life, ordered to see a psychiatrist weekly to manage her medication, and the best part was nobody called me to consult about her well-being, despite me having worked with her for close to a year. According to the family, the psychiatrist's comment when they mentioned me was, "What does she know about this situation? She's not a psychiatrist." The client's never been diagnosed before for anything other than anxiety. She returns home after a month of being locked up in the hospital against her will, while being heavily medicated on very serious medication, only to find out that the college of her profession penalized her for getting hospitalized after receiving records of her pathologizing misdiagnoses from the diagnosing psychiatrist. She then gets increasingly stressed, making her trauma symptoms worse, and we lose about 6 to 8 months of trauma work, having to go back to the basics of setting up housing, making sure she keeps her job to stay financially stable, while ensuring that she doesn't decompensate and start the wheel spinning all over again. How is it that our mental health and addiction system is setting people up to fail just by a person crossing paths with it, sometimes against their will? Okay, I'm going to wrap up because I realize we're out of time. So healing is not just a quick fix. It's a way of life, a way of being. Many people have the assumption that if I just take a little MDMA, I will be cured. From my first-hand experience working with this unique medicine, I can tell you that it's not like that at all. MDMA is a powerful agent on its own. However, coupled with psychotherapy, creates a profound opportunity to heal deep traumatic wounds at the core. MDMA helps to open up the heart through a release of oxytocin so we can feel connected through the social engagement part of our brain and nervous system, also known as the ventral vagal system through Stephen Porges' work. It reduces the activity in the amygdala, which shuts off the threat response, in which most people with PTSD would trigger a fight, flight, freeze, or shutdown responses when triggered long after the event has passed, and in some cases leads to various levels of dissociation, which is drop in consciousness. The amphetamine in the MDMA activates our executive function in the prefrontal cortex, including the medial prefrontal cortex, so that we may be a witness to our experience, creating the connection to ourselves. It also gives us access to our logical, analytical part of our brain in the prefrontal cortex in order to create the necessary neural connections to adaptive information, to create new understanding and realizations, move into acceptance and reprogramming new functional narratives and empowering core beliefs around the past traumatic experience. The MDMA assists with memory reconsolidation of being able to pull up old memories of trauma from our working memory and undo emotional learning that solidified the traumatic imprint in the brain to make the memory more malleable to change, giving permission for a new narrative to be formed, offering an ending to the story of what happened, and finally putting the past in the past with a date and timestamp given by the hippocampus, our long-term memory storage. Once the past is actually perceived as in the past, then the person gains clarity to what is happening in the moment rather than reacting to a past trigger as though it's happening right now. The individual can transition to live fully in the present moment without anticipating the next sudden trigger coming out of nowhere, taking the person into major overwhelm with hyper and hyperarousal of the nervous system. So I'm just going to wrap this up. Preparation and integration are very important aspects of the psychedelic psychotherapy work. Without these pre and post pieces, the MDMA experience is simply just that, a wonderful and uplifting experience. Sub-participants who are coming to us as part of the study have never had the experience of being in a non-ordinary state of consciousness. Thorough preparation for this heart-opening experience is essential in supporting the individual in getting a sense of what to expect for their first encounter with the medicine. It allows us to review the risks and benefits, discuss the impact of the MDMA on the body and brain, share what we have seen in other experimental sessions to help the participant ease into the process, and discuss what is generally expected in terms of this session. We are overdue for a paradigm shift. We can't afford to wait much longer due to the state of our world. We cannot continue the institutional denial of childhood trauma. We have to see the symptoms of addiction and mental health issues as symptomology of trauma. We cannot continue to shame and blame our patients for something that wasn't their fault just because we experience compassion fatigue due to our broken system. We need love and compassion to soften the hearts of those practitioners working in the mental health and addiction system to see the human being that we call our patient. This is the way we break through the powerful entity that we call the mental health and addiction system that has a life of its own and seems stubbornly impossible to transform or shift. The psychedelic medicines teach us about love and compassion for our fellow human beings despite the professional roles we play. We recognize each other as family rather than strangers and are more capable of opening our hearts rather than seeing the patient as the other. We are more genuinely invested in the collective healing of other human beings if we connect on a more intimate level with each other. It's time for a paradigm shift, and that shift is introduction of psychedelic medicine and psychedelic psychotherapy as a potential adjunct solution. Thank you.